Good morning. I'm Dr. Hayes Anderson, and I want to talk to you about something that might seem like a minor inconvenience, but is actually one of the most important early warning signs your body can send. If you're waking up with a dry mouth every single morning, you need to watch this video in its entirety. This is not just about comfort or convenience. This is about a diagnostic signal that your body is sending you, and it could indicate several serious medical conditions that require investigation and treatment. The condition is called xerostomia, dry mouth, and it's epidemic in seniors. Studies suggest that between 35 and 40% of people over 65 experience regular dry mouth, with some estimates in certain populations going as high as 46%. But here's what most people don't realize. Dry mouth is never just dry mouth. It's always a symptom of something else, some underlying dysfunction that needs to be identified and addressed. Your saliva isn't just water. It's not some passive secretion. It's an incredibly complex biological fluid with multiple critical functions. It contains enzymes, particularly amylase, that begin the digestion of carbohydrates. It contains antibodies, particularly IgA, that protect against infection by bacteria and viruses. It contains minerals, particularly calcium and phosphate, that protect your tooth enamel from decay. It contains mucins, which are glycoproteins that lubricate and protect the tissues of your mouth and throat. When your saliva production drops significantly, and that's what's happening when you wake up with a bone-dry mouth every morning, your entire oral ecosystem breaks down. You're at dramatically increased risk for dental caries, for oral fungal infections, for difficulty swallowing, and for nutritional deficiencies because you can't adequately break down and absorb food. But more importantly, that dry mouth is a diagnostic signal. It's telling you that something is wrong with one of 5 major systems in your body. And I'm going to walk you through all 5 because identifying the actual cause is how you actually fix this problem rather than just treating the symptom. The first and most common cause is medication side effects. I'd estimate that nearly 60% of older adults taking multiple medications experience dry mouth as an adverse effect. Here's the problem. Over 400 different medications are known to reduce saliva production. 400. And they work through different mechanisms. Some affect the nervous system signals that trigger salivary gland function. Others directly damage the glands. Still others have systemic effects that reduce fluid availability in your body overall. Now, when you're taking just one medication with this side effect, the impact might be modest. But here's what I see constantly in my practice. Seniors taking 5, 7, sometimes 10 different medications. When you combine medications that all have dry mouth as a potential side effect, the problem multiplies dramatically, and I mean multiplies in a non-linear way. I had a patient, let's call her Margaret, 74 years old, who was taking 6 medications, 2 blood pressure medications, both with anticholinergic properties, a statin for cholesterol, an antihistamine for seasonal allergies, a medication for overactive bladder, and a low-dose tricyclic antidepressant for nerve pain. 6 medications, all with anticholinergic properties, meaning they all interfere with the acetylcholine signaling that's necessary for salivary gland stimulation. Margaret's dry mouth had become severe. She was waking up at 2 and 3 a.m. with her mouth completely parched, requiring water to go back to sleep. She was having difficulty eating solid foods. She'd lost weight because she had to drink liquid with every bite. She was experiencing oral thrush infections repeatedly. Here's the critical piece. The relative risk of severe dry mouth doesn't increase linearly with each additional medication. It increases in a supra-additive manner. One anticholinergic medication might increase dry mouth risk by roughly 20%. 2 medications increase it by roughly 45%. 3 medications increase it by roughly 70%. 4 medications increase it by roughly 85%. This is not additive. This is multiplicative interaction. The most common offenders are first-generation antihistamines, diphenhydramine, chlorpheniramine, certain antidepressants, particularly tricyclics like amitriptyline and nortriptyline, and some SSRIs, blood pressure medications, particularly older beta blockers, and some diuretics. Medications for urinary incontinence, oxybutynin is a major culprit. Certain pain medications, particularly opioids, and some anti-Parkinson medications. If you're experiencing dry mouth and you're on multiple medications, you need to have a very specific conversation with your doctor. Don't just mention dry mouth. Say, I'm experiencing severe dry mouth, particularly in the morning, which is affecting my sleep and my nutrition. I understand this can be a medication side effect. Can we review my medication list specifically to identify which medications have anticholinergic properties and whether there are alternatives available that don't have this side effect? Often there are alternatives. Margaret's case illustrates this. She was switched from amlodipine to a different blood pressure medication class with lower anticholinergic properties, and her tricyclic antidepressant was switched to a different class with lower anticholinergic effects. Within 3 weeks, her dry mouth improved significantly. Within 6 weeks, it was dramatically better. However, and this is crucial, never stop a medication on your own. This adjustment has to be done under direct medical supervision, and it often has to be gradual because stopping certain medications suddenly can be dangerous or cause rebound effects. The second cause is something most people never consider: obstructive sleep apnea. Here's the mechanism. When you have obstructive sleep apnea, your airway collapses during sleep. You're not breathing. Your blood oxygen saturation drops. Your brain senses this dangerous situation and triggers an arousal. You briefly wake up, just enough to gasp and resume breathing. Usually you don't consciously remember these awakenings. You might have 10, 20, 50, or even more than 100 of these events per night in severe cases. During each of these apneic episodes, because your airway is blocked, your body defaults to mouth breathing. Your mouth is open all night, or during significant portions of the night. While your mouth is open, your saliva is evaporating constantly into the bedroom air. There's no moisture sealing your lips. Your saliva glands can't keep up with the evaporative loss. You wake up with a desert dry mouth, but that's just the acute mechanism. The chronic, systemic problem is much deeper and more serious. Sleep apnea causes repeated hypoxic episodes. Your blood oxygen repeatedly drops below normal levels. This triggers systemic inflammatory responses. It triggers repeated sympathetic nervous system activation. And the sympathetic nervous system, when chronically activated during sleep, actually suppresses saliva production. Your body prioritizes other functions, like maintaining heart rate and blood pressure during hypoxia, over saliva production. Moreover, sleep apnea causes chronic inflammation throughout your respiratory tract and throat. That inflammation can directly affect your salivary glands, further impairing their function. Sleep apnea also causes something called oxidative stress, the accumulation of harmful reactive oxygen species. This oxidative stress damages tissues, including salivary gland tissues. Here's what I want you to know. If you're experiencing morning dry mouth, particularly if you also snore, or if your sleep partner has told you that you stop breathing during sleep, or if you wake up gasping, or if you wake up repeatedly feeling like you haven't slept and wake with a pounding heart, sleep apnea should be at the top of your diagnostic list. Sleep apnea is also associated with a tripling of cardiovascular risk, a significant increase in stroke risk, a documented increase in dementia risk, and a significant increase in sudden cardiac death risk during sleep. It's not a minor condition. If you suspect sleep apnea, you need a sleep study. This can be done in a sleep lab setting, an overnight study where you're monitored, or increasingly, this can be done with a home sleep apnea test, which is more convenient and less disruptive. Once diagnosed, treatment is straightforward, usually a CPAP machine that provides positive airway pressure, keeping your airway open at night. In nearly every patient with sleep apnea I've referred for treatment, addressing the sleep apnea resolved the morning dry mouth within 3 to 6 weeks. The third cause is blood sugar dysregulation and diabetes. Here's how this works physiologically. When your blood sugar is elevated, Your kidneys are working overtime to filter that excess glucose and excrete it in urine. This process requires large amounts of water. Your body is essentially becoming dehydrated because water is being pulled from your tissues into your bloodstream to dilute the excess glucose so your kidneys can manage it. Additionally, high blood sugar causes something called osmotic diuresis. Your kidneys actually increase urine output to try to clear the excess glucose. You're literally losing more fluid than you're taking in. Your total body water decreases. Every tissue in your body becomes dehydrated, including your salivary glands. But diabetes doesn't just cause dehydration. Diabetes causes microvascular damage to tiny blood vessels. Your salivary glands depend entirely on intact microvasculature for proper function. Diabetes damages that critical vascular network. Furthermore, diabetes directly damages nerve endings through a process called diabetic neuropathy. Your salivary glands depend on intact parasympathetic innervation, nerve connections to function. Diabetes damages those nerves. If you're experiencing dry mouth, you absolutely need to get tested for diabetes. You need a fasting blood glucose test and, more importantly, an HbA1c test. The HbA1c is the most important test. It shows your average blood sugar control over the past 3 months, giving you a much more accurate picture than a single fasting glucose. If your HbA1c is above 5.7%, you're in the pre-diabetic range. Above 6.5% is diagnostic for diabetes. I had a patient, David, 68 years old, who came in with progressive dry mouth over about 18 months. His primary care doctor had dismissed it as age-related and recommended just using saliva substitutes. But David had a strong family history of diabetes. His mother had type 2 diabetes, and 2 of his siblings had it as well. He was concerned that he might be developing diabetes himself. When I tested him, his HbA1c was 6.1%, pre-diabetic. His fasting glucose was 108 milligrams per deciliter. More tellingly, his insulin level, which no one had measured, was 28 microunits per milliliter, indicating severe insulin resistance. I initiated an aggressive nutrition and exercise program focused specifically on improving insulin sensitivity. No medication yet. We eliminated processed carbohydrates, added more fiber and whole foods, and increased his exercise to 5 days per week. Within 8 weeks, his HbA1c was 5.8%. Within 4 months, it was 5.5%, completely normal range. And remarkably, his dry mouth resolved completely. His salivary function had normalized. The point is, dry mouth can be your first sign of diabetes before any other symptoms appear. By catching it early, you can prevent decades of complications. The fourth cause is more subtle but very common: chronic dehydration with an age-related blunting of the thirst mechanism. After age 65, your thirst perception becomes significantly less sensitive. This is a normal change in aging. Your brain doesn't receive accurate signals about your hydration status. Your kidneys become less efficient at concentrating urine, so you lose more water. Your total body water decreases as a percentage of body weight. This is a normal aging process. And your medications, particularly diuretics, increase fluid loss substantially. The net result: you're chronically mildly dehydrated. You don't realize it because you don't feel thirsty, and your salivary glands, being highly sensitive tissues that require adequate hydration to function, are among the first tissues to suffer. The solution seems simple: drink more water. But it's not quite that straightforward, because the relationship isn't linear. Drinking slightly more water might not have any meaningful effect, but achieving genuine, adequate hydration can significantly improve saliva production. Here's my clinical recommendation. You should be consuming approximately 1 milliliter of water per kilogram of body weight per day, plus an additional 500 milliliters for every 15 minutes of exercise or heat exposure. So if you weigh 70 kilograms, that's 700 milliliters at minimum, but this should be spread throughout the day. Drinking one large volume of water at one time doesn't work as well as spreading intake across the day. Your kidneys can only absorb and utilize about 500 to 600 milliliters of water per hour. Drinking more than that in one sitting is largely wasted. It's excreted unchanged in urine. Optimal hydration strategy: drink about 200 to 300 milliliters of water every hour during waking hours. More if you're exercising or in a hot environment. This creates steady, consistent hydration rather than peaks and valleys. If you're in a dry climate, which is important for seniors in the Southwest and other dry regions, your needs increase by 20 to 30%. If you're on a diuretic medication, your needs increase substantially. The key sign that you're genuinely well hydrated is the color of your urine. If it's pale yellow or clear, you're adequately hydrated. If it's dark yellow or amber, you're dehydrated. This is a simple, free, accessible diagnostic tool. The fifth cause is Sjogren's syndrome, an autoimmune condition that attacks your salivary glands and lacrimal glands, the glands that produce tears. Sjogren's is particularly common in women. About 9 out of 10 Sjogren's patients are female, but it occurs in men as well. It typically appears after age 40, and the incidence increases significantly with age. It's estimated to affect between 1 and 3% of the general population, but the number is likely much higher because many cases go undiagnosed. In Sjogren's syndrome, your immune system mistakenly identifies the epithelial cells of your salivary glands as foreign invaders and attacks them. This causes chronic inflammation and progressive destruction of the gland tissue. The result is profound, often severe dry mouth, sometimes so severe that patients can't eat solid foods without liquid assistance. They have to drink while eating every bite. Sjogren's has specific diagnostic autoantibodies, anti-SSA, also called anti-Rho, and anti-SSB, also called anti-LA. If you're experiencing dry mouth, particularly if you also have dry eyes with that characteristic gritty, sandy feeling, and you have any history of other autoimmune conditions like rheumatoid arthritis or lupus, you should be tested for these antibodies. I had a patient, Eleanor, 71 years old, who came to me with what she thought was just age-related dry mouth. But she also mentioned that her eyes felt constantly gritty and irritated. She'd been to an eye doctor who prescribed artificial tears, but they weren't really helping. She was frustrated and exhausted by the symptoms. When I tested her for anti-SSA and anti-SSB antibodies, both came back positive. Eleanor had Sjogren's syndrome. This was actually good news for her, because Sjogren's has treatments. We started her on a medication called pilocarpine, which stimulates remaining salivary gland function. We also discussed comprehensive oral hygiene modifications, including regular professional fluoride treatments to protect her teeth, which are at extremely high risk for decay in Sjogren's because of the loss of protective saliva. We referred her to a rheumatologist for comprehensive management of the autoimmune condition. The point is, if you have Sjogren's, you need to know it, because untreated, it can lead to severe dental disease, recurrent serious oral infections, difficulty with nutrition, and significant impact on quality of life. Here's something critical to understand. These causes often overlap. A person might have medication-induced dry mouth and also have undiagnosed sleep apnea, or mild prediabetes and chronic dehydration, or Sjogren's and significant medication effects, or all three. When multiple causes are present, the dry mouth is much more severe, and the consequences are much more serious. This is why it's important to systematically evaluate for all 5 causes, rather than just assuming it's age-related. Here's what I recommend for anyone experiencing morning dry mouth. This is a systematic approach. Step 1. Review your medications with your doctor. Ask specifically about anticholinergic properties and whether there are alternatives with lower anticholinergic effects. But do this with your doctor. Don't change medications on your own. Step 2. Get tested for sleep apnea if you have any signs. Snoring, witnessed apnea events, daytime sleepiness, unrefreshing sleep, waking with a pounding heart, gasping awake. A home sleep test is simple, non-invasive, and doesn't require a lab stay. Many insurance companies now cover home sleep testing. Step 3. Get tested for diabetes, fasting glucose, and HbA1c. If your doctor says, "We'll retest in a year," that's not acceptable if you have symptoms. Get tested now. If pre-diabetic aggressive intervention now prevents progression to diabetes. Step 4. Genuinely improve your hydration. Track your urine color. Aim for pale yellow consistently. Spread water intake throughout the day. Step 5. If the above don't resolve your dry mouth, get tested for Sjogren's, anti-SSA, and anti-SSB antibodies. If positive, get a rheumatology referral for comprehensive management. These 5 steps will identify the cause in the vast majority of cases. While you're working through the diagnostic process, here are practical ways to manage the acute symptoms. First, sugar-free lozenges or gum can stimulate residual saliva production. The mechanical stimulation is what matters, not the flavor. Xylitol-containing products are particularly good because xylitol also has some antibacterial properties. Second, avoid mouthwashes with alcohol. They're extremely drying. Use alcohol-free formulations. Third, use fluoride toothpaste and consider fluoride rinses daily. Your teeth are at much higher risk for decay without adequate saliva. Fourth, a humidifier in your bedroom at night can help reduce the rate of evaporative loss from your mouth and respiratory tract. Fifth, if you're severely dry, ask your doctor about saliva substitute products that mimic saliva's lubricating and protective properties. Dry mouth is not a normal part of aging. Yes, it's common in seniors, but common is not normal. It's a diagnostic signal. Work through these 5 causes systematically. Identify what's actually causing your dry mouth, and you can actually fix it rather than just managing the symptom. I'm Dr. Hayes Anderson. Thank you for watching.